তো আমাদের আজকের সাবজেক্ট হচ্ছে গ্লুকোমা। হ্যাঁ, এটা তো একটা রিভিশন ক্লাস। আমি কিছু বলবো আর তোমাদের সাথে কিছু শেয়ার করবো, তোমরা কিছু শেয়ার করবো তোমরা যা জানো। হ্যাঁ? তো আমাদের গ্লুকোমা, গ্লুকোমা প্রথমে ডেফিনেশন। গ্লুকোমা বলতে আমরা কি বুঝি? গ্লুকোমা হচ্ছে progressive optic neuropathy in which there is structural changes in the optic nerve head and functional change in the visual field, where rise intraocular pressure is a risk factor. ঠিক আছে, তাহলে গ্লুকোমার ডেফিনেশন জানতে হবে। এখন তোমাদের সামনে প্রফে এখানে খুব ডিটেলসে যাওয়া হবে না, যেগুলো জানতে চাওয়া হবে অথবা যেগুলো তোমাদের রিটেনে আসবে সেগুলো তোমরা একটু মনোযোগ দিয়ে শুনবা, এবং আমি যেটা বলবো সেটা আবার একটু পরে জিজ্ঞেস করতে পারি, দু একজন হেল্প করবো আমার উত্তর দিয়ে। তাহলে গ্লুকোমা ডিফাইন করলাম কিভাবে, এটা কিছু ক্রাইটেরিয়া বললাম। এটা একটা progressive optic neuropathy pathology হয়, progressive optic neuropathy where structural changes in the optic nerve head and functional changes in the visual field. তাহলে ভিজুয়াল ফিল্ড আমাদের জানতে হবে গ্লুকোমায়, অপটিক নার্ভ হেড সম্পর্কে জানতে হবে, where rise intraocular pressure is a risk factor, যেখানে ইন্ট্রাঅকুলার প্রেসার রেইজ করা এটা একটা রিস্ক ফ্যাক্টর। এখন যেহেতু গ্লুকোমার সাথে ইন্ট্রাঅকুলার প্রেসার রিলেটেড, এখন ইন্ট্রাঅকুলার প্রেসার কি? ইট ইজ দ্য প্রেসার exerted by the aqueous humor and the content of the globe on the lateral surface of the globe. Content of the globe যে প্রেসারটা দেয় on the lateral surface of the eyeball or globe is intraocular pressure. How it is maintained, এখন এটা কিভাবে এই প্রেসারটা হয়? ইন্ট্রাঅকুলার যে কন্টেন্ট আছে, in addition the aqueous humor which is produced by the ciliary process maintain the aqueous intraocular pressure. Now we have to know how the aqueous humor is produced. About the anatomy of the ciliary body, then you see that the ciliary process, which is a part of the uveal tract. You know the uveal tract is uvea, ciliary body, and the iris. The middle part is the ciliary body. The ciliary body or ciliary process is divided into two parts: the anteriorly located pars plicata and the posteriorly located pars plana. The pars plana is nearly to the uveal tract, and the pars plicata is nearly to the iris. And the pars plicata, which circumferentially encircle the eyeball at the just behind the iris level, contains about 70 ciliary processes. The ciliary process again lined by pigmented epithelium and non-pigmented epithelium. And within the lining in the center there is central arteriole, which mainly produces aqueous humor, which passes from the pigmented epithelium to the non-pigmented epithelium. And the non-pigmented epithelium of the ciliary process, uh, having their tight junctions, maintain the aqueous outflow by active transport, sodium potassium ATPase. So aqueous humor is produced from the ciliary process, comes into the posterior chamber through the pupil, then at the angle which is produced by the anterior surface of the iris and the posterior surface of the cornea, the junction where the trabecular meshwork uh, is there. So the aqueous humor produced from the ciliary process comes from the posterior chamber through the pupil into the anterior chamber, then goes through the trabecular meshwork. And this from this trabecular meshwork, it comes into the Schlemm's canal. From the Schlemm's canal, there are aqueous vein and intrascleral venous plexus. From the aqueous vein and intrascleral venous plexus, the aqueous goes through the uh, episcleral venous plexus. Then through the vena porticosi, it goes to the systemic circulation. So what I have said just now is the conventional way by which aqueous is drained from the eye to the system. It consists about 80 to 90% of the aqueous outflow. So I repeat the passage. Conventional way is from the posterior chamber to the pupil, comes into the anterior chamber, then at the angle formed by the anterior surface of the iris and posterior surface of the cornea, goes through the trabecular meshwork. And from the trabecular meshwork, this aqueous is collected by the Schlemm's canal. From the Schlemm's canal, the aqueous is from the Schlemm's canal, the aqueous is collected by the intrascleral venous plexus and aqueous vein. From the aqueous vein, it goes through the episcleral venous plexus, from where it goes through the vena verticosa and to the systemic circulation. Okay. Now the non-conventional pathway. About 10 to 20% of the aqueous flows through this pathway. What is this pathway? The aqueous, as I also already mentioned, from the posterior chamber through the pupil in the anterior chamber, or when within the posterior chamber, it is absorbed by the uveal tissue. Uveal tissue, and there is uh, uh, connection of this aqueous by the uvea, sclera, and goes through the venous plexus over it, and then goes out. That is uveoscleral outflow. The non-conventional passage is uveoscleral outflow. So, why should we know the aqueous drainage system or pathway? Because this is the culprit which causes the glaucoma. When we go to know about the mechanism of glaucoma, then we'll see that there is hindrance of aqueous outflow or excessive production, which is very rare. So uh, we should know about the aqueous outflow to know about glaucoma. Now, if we know something about the trabecular meshwork, because it is needed to know about this open angle glaucoma. The trabecular meshwork, as I already mentioned, is situated at the angle which is present at the anterior surface, peripheral part of the anterior surface of the iris and peripheral part of the posterior surface of the cornea. This trabecular meshwork is then divided into three parts. It is, you may think it as a triangle. The anterior most part or the inner part of the aqueous, inner part of the trabecular meshwork is broader. It is called uveal, uveoscleral part, and then middle part, then outer part. Outer part of the trabecular meshwork, as it is near the Schlemm's canal, which is lined by endothelium, অথবা as it is present near the Schlemm's canal, it is called juxtacanalicular part or uh, endothelial part. The porosity of the trabecular meshwork is at the beginning is about 30 to 50 micron broad. In the middle part, which is about uh, 20 to 30 micron or 10 to 30 micron, and the outer part, which is near the canal, juxtacanalicular part, is narrower and about 10 micrometer, 5 to 10 micrometers. We have to know about the porosity of the trabecular meshwork to know about secondary glaucoma. Now, if I just go to classify the glaucoma, it may be classified in different ways. Simple classification first is congenital, which is born with, that is, the baby born with glaucoma, and acquired. This congenital glaucoma, I will elaborate it rather later. Now, if we classify glaucoma according to mechanism, then there is open angle glaucoma and angle closure glaucoma. And if we classify glaucoma according to any risk factor present with it, then it will be primary glaucoma and secondary glaucoma. So the acquired glaucoma, if we classify it uh, by mechanism to open angle and angle closure, and with associated factors, angle primary and secondary. So in broad sense, glaucoma can be classified as primary open angle glaucoma, primary angle closure glaucoma, secondary open angle glaucoma, secondary angle closure glaucoma. And congenital glaucoma again, it is divided into three parts: congenital, developmental, and juvenile. Congenital glaucoma, if I go through the congenital glaucoma, then congenital glaucoma is the glaucoma, the baby born with glaucoma, that is, glaucoma is present at intrauterine life and the baby born with it. And developmental glaucoma, the glaucoma which develops within the first 3 years of life. And juvenile glaucoma after 3 years to about 18 years. The glaucoma which develops is juvenile glaucoma. Now we go through congenital glaucoma, the clinical feature. There is classical triad in congenital glaucoma, which is this, which constitutes this triad. One is uh, lacrimation, that is tearing by watering. Two is photophobia, intense photophobia. Third is blepharospasm. So if you are asked about the triad of congenital glaucoma, you have to say lacrimation, photophobia, and blepharospasm. When you see any baby with this triad, you think about congenital glaucoma. There are some other causes, but first you think about congenital glaucoma or developmental glaucoma. These are the common symptoms. What are the signs? If you go, if you search for the signs in congenital glaucoma in the cornea, what will you find? In the cornea will be hazy. Due to excessive pressure in the eye, there is difficulty of the corneal endothelial cells to detergence of the water in the cornea. So water is collected in the cornea and cornea is hazy. First one. Second one is the cornea is larger than normal size. Now, what is the normal size of the diameter of the cornea in baby? It is about 10.5 millimeters in diameter. So when we see that the diameter is more than 10.5, then we can gauge it is due to congenital glaucoma. But if it is more than 13 millimeter in diameter, then it is confirmed that the cornea is larger, which may be due to glaucoma, maybe hypermyopia, etc. So the diameter of cornea when more than 13 millimeter, it is called megalocornea and maybe due to glaucoma. Other signs in the cornea, as the cornea increases in size, it disproportionately increases in size, there is break in the decimates membrane, the inner layer of the cornea, endothelial layer of the beneath the endothelial layer, fourth layer of the cornea, which then heals and makes a stria called habstria. So we can find the habstria in congenital glaucoma. Uh, So these are the signs and symptoms of congenital glaucoma, which I have said is classical triad, watering, blepharospasm, and photophobia. Corneal signs, I have said that there is opacity of the cornea or haziness of the cornea. Corneal diameter is increased, which is more than 13 millimeter, and there is hepatria. Some scleral signs also there, which are that as the sclera also stressed, the underlying tissue, choroidal tissue, uveal tissue are seen, which are bluish in color because uveal tissue is highly vascular and bluish coloration of the sclera is seen. So these are the signs and symptoms of congenital glaucoma. What should we do for it? For congenital glaucoma, we have to go. Uh, this is confirmed by and IOP is measured. So because the examination of the baby is very difficult. The baby is examined under anesthesia. We call it EUA, examination under anesthesia. And what should we see at the examination? We should first see measure the corneal diameter by calipers. Then by portable slit lamp, we see the corneal status, the iris, if the cornea is clear, the iris status, the angle structure by gonioscope, and measure the intraocular pressure by shear stonometer, uh, etc. And then we come to diagnosis that this is the congenital glaucoma. What are the treatment? As in congenital glaucoma, the cornea is hazy. We have to reduce the IOP, intraocular pressure, by anti-glaucoma drugs. And when the cornea is clearer, then we go to surgical treatment. What are the surgical treatment for congenital glaucoma? We may do uh, trabeculate, trabeculectomy, which can be done outer from the external of the eye or internal. From the external, we use a knife, a sharp knife, which is called Barkan's knife. By the Barkan's knife, we enter into the anterior chamber through the limbus at the temporal side and cut the trabecular meshwork. Trabecular meshwork. As we know, in congenital glaucoma, the pathology is trabecular uveo-trabecular dysgenesis or trabecular dysgenesis. Trabecular, there is problem in the trabecular meshwork. If we cut open the trabecular meshwork, then the aqueous will go through that pathway and the pressure will be reduced. But if the cornea is hazy, then we cannot do it because we cannot see the angle structures by gonioscope during the procedure. At that case, we use another trabeculectomy knife, which is guided by outward. And if this is not working, then we go through trabeculectomy, the bypass operation for glaucoma. So this is about congenital glaucoma. Uh, would anyone please help me by saying what is glaucoma? Hello?
Sir, glaucoma is a chronic progressive optic neuropathy with
Yes.
its characteristics structural and functional change with or without rise in the intraocular pressure.
Thank you. With its characteristic changes in the structural changes in the optic nerve head, hmm? Optic
Yes, sir.
nerve head, and functional change in the visual field. Just
Visual
you
field.
clear this and visual field. When you are asked any type of glaucoma, if you remember the three criteria, chronic progressive disorder, the structural change, the structure, which structure? Optic nerve. What are the changes in the optic nerve? Optic nerve cupping. There is cupping. You know about the cupping, cup disc ratio. The cup is the central portion of the optic nerve head. Okay, and the disc is the peripheral circumference. If we say the cup is 3, the disc is 10. The normal cup disc ratio is therefore 0.3. Understand? The cup disc ratio is normally 0.3. When there is glaucoma, there are some pathological pathology which causes the cup disc ratio to increase. When there is glaucoma, the cup is increased, but the disc is as its size. If the cup from 3 to 6, then it will be 0.6. This is a pathological condition. When when the cup is uh, uh, 8, then the cup disc ratio will be 0.8. These are pathological conditions. So when the cup disc ratio is more than 0.3, this may be pathological, but not always. Why not always? If you compare the two eyes of a single patient, if there is a difference between two or more in the cup disc ratio, then it will be pathological. I will clear you about it. That is, if right eye cup disc ratio is 0.5 and left eye is 0.35, that is the difference is 1.15. This may not be the pathological condition, though it is zero point 0.5, where the normal is zero point 0.3. If you say one cup disc ratio is zero point 0.5 and other is zero point 0.2, then the zero point 0.5 is pathological. So then we search for other factors. What are the other factors? Other factors, visual field analysis. We do visual field analysis. And if the visual field analysis is always pathological, that is constriction of the visual field, as we do it by clinical examination, confrontation test. You already, I think, do it. Confrontation test, the visual field is constricted and we find the IOP is raised, then it will be glaucoma. Now I have, now the congenital glaucoma I have said to you, and depending upon the mechanism, I already said you open angle and angle closure. So we have to know about the angle of the eye. The angle of the eye, as I already said, is formed by the peripheral part of the anterior surface of the iris and peripheral part of the posterior surface of the cornea, where the trabecular meshwork is present. In open angle glaucoma, this angle is open. That is, when we, how can we examine the angle of the eye? We can examine it by gonioscope. Gonio means angle. So gonioscope, to see, scope means to see. To see the angle structure by instrument is called gonioscope. The gonioscope shows that the angle is open. That is, you can see through the gonioscope the trabecular meshwork at different levels. When the trabecular meshwork is seen, then it is open angle. When the trabecular meshwork cannot be seen by gonioscope, it is angle closure. Now, what are the pathology or why the angle open but there is glaucoma? Where is the hindrance of aqueous outflow? The aqueous outflow occurs at different levels. As I already mentioned you about the trabecular meshwork, which is crucial to know about the glaucoma, open angle glaucoma mechanism. In open angle glaucoma, the trabecular meshwork may be blocked by different ways. It may be blocked by the lens particle. It may be blocked by the protein which is produced by uveitis. It may be blocked by RBC or blood cells which is produced by trauma, and so on. So this particle, when come into contact with the trabecular meshwork, then the trabecular it goes through the trabecular meshwork. As I already mentioned, that the trabecular meshwork porosity extends from 5 micron to 50 micron. As the 50 micron is in phase in front, so the particles which I already mentioned, RBC, WBC, dense particle or other proteins, this go through the trabecular meshwork in its first phase. But when it comes into the middle structure of the trabecular meshwork, it may get a hindrance or uh, there will be a blockage. Then the aqueous cannot pass through the trabecular meshwork. You remember that in that case, the angle is open. Through the angle, it goes through the trabecular meshwork and uh, blocked there. So the aqueous cannot pass through the trabecular meshwork. Which is the transitional area? We cannot pass through the trabecular meshwork to the SOMC canal. So the intraocular pressure become raised. As the intraocular pressure becomes raised, there is second open angle glaucoma. Uh, you can classify this open angle glaucoma in as primary and secondary. When we know the cause is due to lens protein or due to uveitic protein or due to WBC, RBC or so on, then we call it secondary open angle glaucoma. When we cannot find any cause in the eye or systemic, then we call primary open angle glaucoma. So I have mentioned you about the open angle glaucoma. Now angle closure glaucoma. Here we have to remember again about the angle. Do you help me by saying the angle structure of the uh, eye? Anyone, please?
So the angle is formed by
Uh,
the peripheral part of the anterior surface of the iris and peripheral part of the posterior surface of the cornea.
okay, thank you. Now, if we know the structure as we know, then there will be angle closure. How can it be closed? It can be closed by two ways. First is anterior force. That is the force exerted from the anterior part of the iris. And when the force is exerted by the posterior part of the iris, then we call it posterior force. So when which is the anterior force? In some condition, there are some pathological structure in the angle, as we say in rubeosis iridis. Rubeosis iridis is a term used for new vessels uh, produced over the iris and angle. Rubeosis iridis is the new blood vessels which are produced over the iris and the angle structures and maybe on over the cornea. These new vessels have contractile force. These new vessels have endothelial lining and some elastic fibers, but there is no basement membrane. As the membrane is formed, these new vessels, then this as they contain the trabecular meshwork, as they contain the elastic fibers, these elastic fibers are attached to the trabecular meshwork as well as the anterior surface, peripheral part of the anterior surface of the iris, and they contract. When they contract, they pulls the peripheral part of the iris towards the cornea, and by this way they block the trabecular meshwork. That is, the angle is blocked. If we see through the gonioscope at this stage, we cannot identify the trabecular meshwork. When we don't identify the trabecular meshwork, we call it angle closure glaucoma. As the iris is pulled forward by the anterior force, the anterior chamber depth, which is reduced in that case. This is the anterior force. And the posterior force, which is what is it? The posterior force is, in case of chronic uveitis, there is posterior synechia. You know the term synechia? This is the attachment of the iris with the lens. When iris is attached with the lens capsule, it is iris goes posteriorly, so it is posterior synechia. The iris may go to the anteriorly to the cornea and anterior synechia. So here is in posterior synechia, if the synechia is 360 degree, if the synechia is 360 degree, that is the iris is attached with the lens capsule throughout the pupil, then no aqueous comes through the iris from the posterior chamber through the pupil into the anterior chamber as there is synechia. So the aqueous produces a force over the peripheral part of the iris as it cannot go through the pupil. This will produce a forward bulging of the iris, and this forward bulging may block the angle structures, which may be which may cause the angle closure. So we now understand the angle closure glaucoma. When we know the causes, then we call it secondary angle closure glaucoma. When we don't know about the causes, then we call it primary open angle glaucoma. Now
স্যার
there are some other sorry.
স্যার anterior স্যার the force এর মেকানিজমটা আরেকবার বলেন স্যার অ্যাঙ্গেল ক্লোজার গ্লুকোমাতে।
Okay. Anterior force. You have to think about something problem abnormality in the anterior chamber. What are the abnormality? There may be abnormal membrane or abnormal blood vessels. I explained you about the abnormal blood vessels. These are called rubeosis iris. The abnormal blood vessels contains elastic fibers and endothelial cells. These elastic fibers or endothelial cells are situated in the angle, that is in the trabecular meshwork. They are attached in the trabecular meshwork as well as the peripheral part of the iris. As the trabecular meshwork is a solid structure and it is a stable structure, it cannot move as the elastic fiber contracts. When it contracts the peripheral part of the iris towards the trabecular meshwork. You understand? So the
Yes sir.
peripheral part of the iris comes over the trabecular meshwork and attached to the cornea, thus hindering the aqueous outflow from the posterior chamber through the pupil. It comes from posterior chamber through the pupil to anterior chamber, but it cannot find the trabecular meshwork from where it goes out of the cornea because of the attachment of the peripheral part of the iris to the cornea, peripheral part of cornea. So the anterior force produces raised intraocular pressure. I give you an example, only the rubeosis iris. There are some other causes. There is abnormal membrane due to trauma of the cornea that we call iridocorneal endothelial syndrome. That is iris and cornea between a endothelium চলে আসে। iridocorneal epithelial syndrome আছে। এরকম abnormal membrane যদি কোনো কারণে trabecular meshwork-কে ব্লক করে দেয়, এটাও অ্যাঙ্গেল ক্লোজারের anterior force হিসেবে কাজ করতে পারে। তাহলে এটা গেল গ্লোকোমার ক্লাসিফিকেশন। এখন এগুলা বললাম আমরা গ্লোকোমার ক্লাসিফিকেশনে মেকানিজম এবং ফ্যাক্টরস এর উপর ডেভেলপমেন্টাল। এখন এছাড়াও কিছু গ্লোকোমা আছে যেগুলা এই যে গ্লোকোমার প্রথম যে ডেফিনিশনটা আমরা দিছি যেখানে রেইজ অফ ইন্ট্রাঅকুলার প্রেসার ইজ এ রিস্ক ফ্যাক্টর, এখন প্রেসার রেইজ না করেও গ্লুকোমা হতে পারে, যেটাকে আমরা বলি নরমাল টেনশন গ্লুকোমা। তাহলে নরমাল টেনশন গ্লুকোমাটি কি? ওই যে ক্রাইটেরিয়া যেগুলো বলছিলাম এগুলো সবই থাকবে যেখানে প্রেসারটা শুধু নরমাল থাকবে। অর্থাৎ এটা প্রোগ্রেসিভ অপটিক নিউরোপ্যাথি পাবো, where there is structural changes in the optic nerve head পাবো, অর্থাৎ কাপ-ডিস্ক রেশিও আমরা বেশি পাবো, এবং ভিজুয়াল ফিল্ড অ্যানালাইসিস করলেও আমরা কনস্ট্রিকশন অফ দ্য ভিজুয়াল ফিল্ড পাবো। বাট when we measure the intraocular pressure, it will be within teens, that is 19, 18, 17 or so on. This is normal tension glaucoma. That is, the features of the glaucoma are there, but the pressure is normal. There is other condition, ocular hypertension. That is, we will get the pressure raised, but there is no changes in the optic nerve head or visual field. If we get the pressure is 25, but the optic nerve head, that is cup-disc ratio, is 0.3, and the visual field is normal, then we call it ocular hypertension. we don't know, don't want to know it about. We don't want to know it elaborately about it. Just the pressure is increased and the other features are normal. It may be due to trauma and so on. And now, if we go through the uh, primary and secondary open angle glaucoma, what are the clinical features and what are the factors causing the open angle glaucoma? In case of primary open angle or secondary open angle glaucoma, there are some risk factors. In primary open angle glaucoma, risk factors are uh, age about 40 or more. The open angle glaucoma usually don't occur before 40. Secondary open angle or primary open angle glaucoma. The age increased and the chance of occurring glaucoma is more. And sex is usually female more than male. Race, if you think about the race, it is more in black. And what are the clinical features of open angle glaucoma? In case of sign, there is usually no sign. When the patient comes to us for spectacle changes, or he sometimes says that frequent change of spectacle, that is, as it occurs after 40, the patient says that I have taken the spectacle, presbyopic glass for reading 3 months ago, but I cannot see very well with this. This may be a complaint, that is frequent change of spectacles. Why it is? Why is frequent change of spectacles? The mechanism is, as there is pressure in the eye, it may hardens the suspensory ligament, which slackens the lens, intraocular lens. As the suspensory ligament hardens, it cannot focus in front. So it is difficult to focus in front. So the spectacle power cannot support him to see the near objects. For this reason, the spectacle change may be. And other sometimes someone says halos around night is very rare, very rare. Scotomas, they are very rare. The in primary or secondary open angle glaucoma, there is usually no symptoms. What are the signs? For documenting the signs, we have to examine the eye by first, in all cases in ophthalmology, we have to examine the eye by slit lamp. With slit lamp, we say that the uh, cornea is clear, the diameter is normal, the pupil is almost reacting, but there is, when we measure the intraocular pressure by uh, planation tonometer, we found that there is raised intraocular pressure. Then we have a suspicion that there may be glaucoma. For to confirm this, we have to examine the posterior segment, that is the retina, especially the optic nerve edge. And by ophthalmoscope, direct or indirect ophthalmoscope, we examine the optic nerve and the cup disc ratio is measured. Uh, uh, it may be zero point 0.3, zero point 0.4, zero point 0.5, zero point 0.6, so on. So if the cup disc ratio is zero point 0.6, we find the IOP is raised, then we may call it glaucoma. But what type of glaucoma? Either open angle or angle closure. To differentiate it, we have to examine the angle structures by gonioscope. When we examine the angle structure, that is the trabecular meshwork is well seen, and the anterior chamber depth is well, then we say it open angle glaucoma. So the signs are raised intraocular pressure, increased curve disc ratio, and the angle is open, and it is always adult onset. And what are the examinations we should do for this glaucoma? The visual field analysis. We can examine the visual field by clinically by confrontation test. You are in the examination, you are asked sometimes, what is the clinical method of examining the visual field? This is confrontation test. That is, the patient will sit in front of the examiner about a meter, and the examiner will hold his right eye with right hand, and the examinee will hold his left eye, that is in front. Confrontation test. The patient's right eye, if the patient's right eye, the examiner's left eye, or if the patient's left eye, the examiner's right eye will be closed. Then the other eyes are open, and the examiner uh, uh, moves his finger or a bright object or a light from the peripheral part to the center and asks the patient where he could see. There is some limitations here. If the examiner holds the spectacle, then his visual field is constricted. He cannot examine this in that cases. So this is the clinical examination of visual field. How can we examine this visual field by investigation? By visual field analyzer. We commonly use Humphrey's visual field analyzer. Sometimes we use Octopus visual field analyzer. Whatever you use, there is some protocols for them, but any one of the two can be used and document the visual field constrictions or not. And by IOP, we can measure it by digital tonometry. Digital tonometry is the digit of the hand, that is fingers of the hand, by pressing, just it is examining the fluctuation test of the eye. Uh, the fluctuation test, we can have a idea about the intraocular pressure. We cannot say it, that is the intraocular pressure is 20 or 30 or 40, but we can uh, give an idea that the intraocular pressure is raised or not. When we think the intraocular pressure is raised, then we go for intraocular pressure measurement. That can be measured by uh, tonometry. What are the tonometries? There are two types of tonometry. One is Shear's tonometry, so that is conventional and less cost effective and is useful in everywhere. It doesn't need any electricity or very much expertise. Just we anesthetize the eye by surface anesthesia and keep the applanation tonometer, that is Shear's tonometer, over the center of the cornea. There is a plunger in the tonometer. The plunger is fixed, is attached with a scale which shows the intraocular, which shows 0 to 20 marking. This 0 to 20 marking uh, shows in a pressure chart where 20 may show the pressure is 10 or 15, like that. We don't remember it, but there is a chart, and from the chart we get the intraocular pressure. This is the intraocular pressure measurement by Shear's tonometer. This is the old method. What is the newer method? The newer method is applanation tonometer. This is a slit lamp held tonometer. We have it in our Osmani Medical College Hospital. I think you have already seen it. And how the pressure measure, I think you already see it. The patient is patient's eye is anesthetized by surface anesthesia, and the patient is sit in front of the slit lamp. As we examine the eye by slit lamp, here the patient is seated in front of the slit lamp, and the applanation tonometer is touched with the cornea of the patient, and there is a knob which measures the intraocular pressure. There is uh, 0, 1, 2, 3 to 10. The 0 means 0, 1 means 10 intraocular pressure, 20 means 22 means 20 intraocular pressure, and so on. In between 1 and 2, there is some markings, 5 markings, which indicate that 1.2 is 12, 1.4 is 14 millimeter of mercury. So by this way, we can measure the intraocular pressure. There are some other intraocular pressure machines. They are air optometry. We use it in Sylhet. Uh, this is this gives a better result, but it is costly, and it it is helpful in case of uh, communicable diseases because it doesn't touch the eyeball. Only the air pushes the eyeball, and there is a reading of the intraocular pressure. So by this way, we can measure the intraocular pressure, and I have already say you about the angle structure. How can examine the angle structure is examined by gonioscope, which is a slit lamp aided instrument. Here, the patient also sits in the slit in front of the slit lamp and keep his mouth in front of the slit lamp, and we touch the gonioscope over the cornea. We fit it over the cornea. So, as it is touched the cornea, the eyeball must be anesthetized by surface anesthesia. And then we look through the slit lamp. The angle structures are examined by this way. Now we go for treatment. The treatment of glaucoma, there is a target pressure. We have a target. We don't want to decrease the intraocular pressure from 50 to 10 at a time. So we have a target. What is the target? The target is be, to set a pressure, the target pressure. What is the target pressure? The target pressure, sometimes you are asked in the examination by the board, what is the target pressure? It is the pressure below which further damage of the optic nerve is unlikely. The pressure, the intraocular pressure below which further damage of the optic nerve is unlikely. So, how can we determine the target pressure? This is grossly, the measurement is like that. If the intraocular pressure on first visit is 40 millimeter of mercury, then the target pressure will be 40% reduction of that pressure. That is, the 40% of 40 millimeter mercury is 16 millimeter of mercury. So we will reduce 16 millimeter of mercury. So in case of 40 millimeter mercury patient, the target pressure will be 26 millimeter of mercury, and so on. So if the pressure first visit is 30, then it will be 30% reduction. That will be 9. So the target pressure will be 11, 21. So first we should determine a target pressure, and then we proceed. So after the determination of target pressure, we will proceed whether which medication we will give. And there are some basic principles in glaucoma treatment because glaucoma is a lifelong disease. It will not be cured until surgery. So some patients don't want to be undergone surgery. You have to continue the medication for lifelong. So when you think about the medication, you must think which which drug is cheap, which should be given infrequently, that is once a day, which drug is easily available. This should be considered first, and the condition of the patient, because as we already said, the patient have to continue the drug lifelong. So the drug should be low priced, easily available, infrequent dropping, and less side effect. These are the basic principles before giving glaucoma medications. And what drug should be used? What drug usually used? There are some beta blockers, some adrenergic blockers. We know the adrenal receptors are alpha 1, alpha 2, beta 1, and beta 2. Alpha 2 is present in the ciliary epithelium. That is, as I first mentioned, the ciliary epithelium, which produces aqueous humor from the ciliary process. If we reduce the production of aqueous from the ciliary epithelium, then there will be reduction in pressure. So the alpha 2 receptor, which is present in the ciliary epithelium, when stimulated, you remember, when stimulated, they block aqueous humor production. You understand? I say it here. Ciliary epithelium contains alpha 2 agonist with alpha 2 receptors, which, when stimulated, they block the ciliary epithelium to produce aqueous humor. On the other hand, there are some beta blockers. What and beta receptors, beta 1 and beta 2. Some drugs acts on the beta 1, they are cardioselective. We don't want to know about it not much now. And some are beta 2, comparatively beta 2 selective. We use these drugs, beta blockers, beta 2 receptor blockers. These beta 2, where they are present? They are present in the bronchial epithelium and in the ciliary epithelium. When they are stimulated, you carefully hear that when the beta receptors are stimulated, then aqueous humor production is increased. Aqueous humor production is increased, whereas alpha 2 stimulated, aqueous humor production is decreased. So we don't want to stimulate the beta 2 receptors. We want to block this beta 2 receptors. So the drugs name are in a group beta blockers. We use the beta blockers. These beta blockers block the beta 2 receptors and thus reduce the production of aqueous humor from the ciliary epithelium. Uh, so before giving the beta blockers, we have to consider about the patient's condition. It also reduces the pulse rate, heart rate. So if the patient is bradycardic, then we don't want to use these beta blockers. If the patient is asthmatic, it will worsen his or her condition. So we have to consider the previous condition of the patient. If the patient, we have to take history about the bronchial asthma, and we have to measure the pulse rate before prescribing beta blockers. So what beta blockers are present in our market? Commonly, we use timolol. Timolol is the drug of choice still today because it is a easily available drug. It has less side effects excepting beta bradycardia and bronchial asthma. If the patient is not bradycardic or no bronchial asthma, we can easily consider beta blockers. This reduces the intraocular pressure by blocking the beta receptors in the ciliary epithelium, and thus the aqueous humor production is reduced. There is some common side effect, irritation, and allergic reactions to drug. There is some blurring of vision. Sometimes some may say there is anesthesia of the eye. These are some side effects of the beta blockers. And we use beta blockers usually twice daily, 2 times daily. There are some beta blockers selective bitoxolol. This is better than beta timolol in that sense that they have a action on UV scleral outflow also. That is, they reduce the aqueous humor production and as well as they increase the outflow, thus reduces the intraocular pressure. And there is also a positive effect of bitoxolol over the nerve tissue. That is, they uh, increases the nerve growth factor to the optic nerve. So they reduces the cupping, which is very much helpful. This is about beta blockers. Now we can also use acetazolamide. Acetazolamide is carbonic anhydrase inhibitor. This carbonic anhydrase inhibitor inhibits the carbonic anhydrase, thus reduces the aqueous flow from the tight junctions of the ciliary process, and aqueous cannot come out. There are some prostaglandin analog. Prostaglandin, what are they? They are I have already mentioned you alpha 2 agonist, but not the name. The name is brimonidine. Brimonidine tartrate is used as alpha 2 agonist. And timolol, I have already said timolol and betoxolol for beta 2 antagonist, beta blocker. And now the prostaglandin analog, they are latanoprost, travoprost, bimatoprost, uniprostol. These four drugs more commonly used are travoprost and latanoprost. How they work? They work. They increases uveoscleral outflow. They increases the uveoscleral outflow, and the uveoscleral outflow is increased, and the aqueous intraocular pressure is reduced. And lastly, we sometimes we may use mannitol to reduce the intraocular pressure urgently. This is usually used in case of acute angle closure glaucoma or before surgery to reduce the intraocular pressure. And lastly, for secondary open angle glaucoma, we do surgery. What is the surgery? The surgery is trabeculectomy. This is a surgical bypass procedure by which the aqueous is drained from the posterior chamber through the trabecular meshwork into the sub space, subconjunctival space, and then collected by the veins over the sclera. Thus, the intraocular pressure is reduced. So, I have tell you about the secondary open angle glaucoma. Your time is short. Now you are sometimes questioned in the written question or viva. What are the lens-induced glaucoma? But Phycogenic glaucoma. Phaco, you know, the lens is called phaco. Phacogenic, that is the glaucoma produced by lens. So what are the phacogenic glaucoma? The phacogenic glaucoma, again, we can classify it into two parts. One is open angle and another is angle closure. What is the open angle type? Phacogenic glaucoma. In phacogenic glaucoma, in open angle, there is phaco antigenic, and lens particle. These three types causes open angle glaucoma. What is phacolytic? That is, in case of hypermature cataract, there is the lens capsule which covers the lens particle and nucleus become porous, and the porosity permits the lens particle to come out of the lens. And when the lens particles comes out, they are engulfed by the macrophage present in the aqueous humor. This macrophage-laden lens particle comes from the posterior chamber through the pupil into the anterior chamber and blocks the trabecular meshwork. As the trabecular meshwork is blocked over and over, then the aqueous cannot go through the trabecular meshwork because they are blocked up, blocked by the lens particle and by the macrophages laden lens particle. This is phacotoxic. Phacotoxic. Lens particle glaucoma. This is simple. The lens particle comes out of the lens due to trauma or after surgery. They go through the trabecular meshwork and block the trabecular meshwork, causing raised intraocular pressure. And phacoanaphylactic. This is one. Phacoanaphylactic. There is anaphylactic reaction. What is the anaphylactic reaction? As the lens protein is sequestrated within the lens capsule, they cannot come out usually. But when there is pathological condition or after surgery or trauma, the lens particle comes out. And after some time, there will be a antigen antibody reaction, as this acts as antigen not known to the eye about the lens particle, as it is sequestrated within the lens capsule. They comes into the anterior chamber and produces an anaphylactic reaction, which takes time. So the anaphylactic reaction or phacoanaphylactic glaucoma occurs few days or weeks after the operation or trauma. These are secondary open angle glaucoma produced by lens. And what are the angle closure glaucoma? These are phacomorphic. That is, morphology of the lens is increased day by day by hypermature by intumescent cataract. As in intumescent cataract, the lens structure is increased in size as it contains water and some other substances within the lens particle, and the lens becomes more in size, and it slankens the ciliary muscles, so the lens comes forward, and the iris is in contact with the lens, blocking the aqueous humor to come from the posterior chamber to the pupil to anterior chamber, as it is blocked by the iris and lens. That is, the iris lens diaphragm uh, produces a diaphragm and uh, give a hindrance to aqueous outflow from the posterior chamber to the anterior chamber to pupil. As that aqueous cannot come through this way, they produces a posterior pressure. I have already mentioned about it. The posterior pressure is produced, and the aqueous produces the pressure over the posterior surface of the iris, which blocks the angle structures. That is the trabecular meshwork. So there will be pressure rise and angle closure. And sometimes there is phacotropic. Phacotropic, that is, the lens position is abnormal. That is, the lens is not within its space. That is, the lens may be dislocated anteriorly. That is, the lens is over the iris, blocking the aqueous outflow. That is, in front there is lens, and in behind the iris, and the aqueous cannot passes from the posterior chamber to the anterior chamber due to blockage of the iris lens diaphragm. So this is the lens-induced glaucoma. Now, can you say what are the causes of glaucoma by lens? Uh, Anyone, please? Mohammed Ghulam Kibriya, will you help me? Mohammed Ghulam Kibriya?
Yes, sir.
What are the causes of lens-induced glaucoma? This question, every year you will face this question.
Phacoantigenic, phacolytic,
Okay. Yes, anaphylactic, phacomorphic, phacotropic. Phacomorphic, phacotropic, phacoantigenic, that is phacoanaphylactic, phacotoxic, and lens particle glaucoma. Okay, thank you. So I have already I mentioned, and now we will discuss about how can we diagnose glaucoma. Golam Kibriya দেখি বলো তো, গোলাম কিবরিয়া আছো?
Yes, sir.
হ্যাঁ, তুমি আবার বলো যে কিভাবে আমরা গ্লুকোমা ডায়াগনোসিসের জন্য প্রসিড করব। এনি টাইপ অফ গ্লুকোমা, হাউ উই প্রসিড। তুমি যেটা মনে হয় এতক্ষণ যা বলছি এর উপর ভিত্তি করে তোমার কাছে যেগুলো মনে হয় আমি দরকার হয় কারেকশন করে দেব। বলো।
Sir, sleep lamp,
হ্যাঁ,
biomicroscope.
বলো।
Sir, sleep lamp, biomicroscope.
যে পরীক্ষা করব, ঠিক আছে। তারপরে
Sir, applanation tonometry দিয়ে intraocular pressure check করব।
মাপবো, ঠিক আছে। তোমাদের যখন এই যে এই কোশ্চেন গুলো করবো, হ্যাঁ, তোমরা আগে মনে করবো ওই গ্লুকোমার ডেফিনেশনে কি বলছিলাম, এটা প্রোগ্রেসিভ অপটিক নিউরোপ্যাথি, যেখানে তোমার স্ট্রাকচারাল চেঞ্জেস অফ দ্য অপটিক নার্ভ হেড। তাহলে অপটিক নার্ভ হেড দেখতে হলে আমাদের অপথালমোস্কোপি করতে হবে, হ্যাঁ।
জি স্যার।
আর ফাংশনাল চেঞ্জ অন দ্য ভিজুয়াল ফিল্ড, তাহলে কিছু ক্লিনিক্যাল এক্সামিনেশন করতে হবে। তাহলে আর এই এক্সামিনেশনে যাওয়ার আগে আমার হিস্ট্রি নিতে হবে। হ্যাঁ, যখন তোমার কোনো রোগ ডায়াগনোসিসের জন্য প্রসিড করতে বলা হবে, তখন ফার্স্ট তোমার চিন্তা করতে হবে, তোমার হিস্ট্রি নিতে হবে। ফার্স্ট হিস্ট্রি টেকিং, দেন এক্সামিনেশন, দেন ইনভেস্টিগেশন, দেন কনক্লুশনে যাওয়া যে কি করব। হ্যাঁ, তো ঠিক আছে, তোমার এই স্লিপ ল্যাম্প এক্সামিনেশন তো করতেই হবে। তো ফার্স্ট আমি হিস্ট্রি নেব পেশেন্টের, যে বয়স কত তো আমি তো পাবোই, তার তো নেম এস এক্স কিন্তু কমন তো হিস্ট্রি আমরা নিবই। এখানে বয়স পাবো আমরা যদি কনজেনিটাল না হয় সেক্ষেত্রে 40-এর উপরে, কমনলি 40-এর উপরে। তাহলে এইজ পাইলাম 40-এর উপরে। হ্যাঁ, ফিমেইলে কমনলি হয়। তারপরে তার সিমটম কি সে বলবে যে আমি ফ্রিকুয়েন্ট চেঞ্জেস অফ গ্লাস, অথবা অ্যাকিউট তো আমি বলি নাই, আজকে সময় নাই বলতে পারবো না। অ্যাকিউটে তার প্রচন্ড পেইন হবে, বমি হবে, রাত্রে ঘুমাইতে পারবে না, যে যাই হোক এইরকম কিছু সাইন সিমটম দেবে। যেহেতু সেকেন্ডারি ওপেন অ্যাঙ্গেল গ্লোকোমা বা প্রাইমারি ওপেন অ্যাঙ্গেল গ্লোকোমায় সিমটম নাই, সে তেমন কিছু বলবে না। হ্যাঁ, তো যে আমার মাঝে মাঝে গ্লাসটা চেঞ্জ করা লাগে, আর তেমন কিছু বললো না। তখন তোমাকে বের করতে হবে যে কি তাহলে আছে, কি আছে দেখতে হলে প্রথম অপথলমোলজিস্টের প্রথম কাজ হলো স্লিট ভিশন দেখা। আর ভিশনও আমরা গ্লুকোমায় একেবারে এন্ড স্টেজ না গেলে তার ভিশন ভালোই থাকবে, 6-6 ও থাকতে পারে। হ্যাঁ, তাহলে ভিশনও পাইলাম নরমাল, ভিজুয়াল অ্যাকুইটি, আই মিন ইট ভিজুয়াল অ্যাকুইটি is 6-6. Then we go through slit lamp examination. By slit lamp examination, we use gonioscope with the help of slit lamp examination, IOP measurement by tonometer. Huh? And indirect ophthalmoscopy can be used to see the optic nerve head. So by slit lamp examination, we have a gross idea about the eye. What anterior chamber is shallow, where is the iris is anteriorly positioned or posteriorly positioned, pupil is attached to the lens, that is synechia, or there is uveitis, or there is blood, এরকম কিছু আছে কিনা আমরা স্লিট ল্যাম্প এক্সামিনে দেখলাম। এরকম কিছু পাইলে আমরা ওই লাইনে চিন্তা করব। যদি না পাই সেক্ষেত্রে আমরা স্লিট ল্যাম্পের মাধ্যমে আমরা যে স্ট্রাকচার গুলো দেখলাম, দেখার পরে আমরা আইওপি মেজার করলাম, ইন্ট্রাকুলার প্রেসার মেজার। ইন্ট্রাকুলার প্রেসার মেজার করে আমরা ধরো পেলাম এখানে 30, তাহলে এটা আমরা মার্ক করলাম ইন্ট্রাকুলার প্রেসার। আমরা সাধারণত দুই চোখেরই দেখি। হ্যাঁ, তো দুই চোখেই দেখলাম, এক চোখে পেলাম 30 আর এক চোখে পেলাম 20 বা 15। তাহলে যে চোখে 30 আমরা সাসপেক্ট করলাম এই চোখেই অসুবিধা, তখন আমরা চোখ ডাইলেট করে চোখের অপটিক নার্ভ হেড দেখবো। এটা আমি ওই যে বললাম যে অপথলমোস্কোপি আমরা দুই ভাবে করতে পারি, ডাইরেক্ট আর ইনডাইরেক্ট। ডাইরেক্ট হচ্ছে তোমরা দেখছো অপথলমোস্কোপ, দেখছো নিশ্চয়ই। অপথলমোস্কোপ দিয়ে আমরা যে অপথলমোস্কোপিটা করি ওটা হলো ডাইরেক্ট অপথলমোস্কোপ। আর ইনডাইরেক্ট হলো স্লিট ল্যাম্পের সামনে একটা ভক লেন্স বলে, VOL কে ভক, ভক লেন্স 90 ডায়াপ্টার আছে, 78 ডায়াপ্টার আছে। এটা স্লিট ল্যাম্পের সামনে ধরলে আমরা পোস্টেরিয়র সেগমেন্টটা দেখতে পাই। তো পোস্টেরিয়র সেগমেন্ট দেখলাম, কার্ভ রেশিও আমরা এখানে মেজার করলাম, তাহলে পজিটিভ পাইলাম আইওপি 30, কার্ভ রেশিও পাইলাম ধরো 0.6। তাহলে এটা দিয়ে আমরা ধরে নিলাম তার গ্লুকোমা। এখন এটা গ্লুকোমাটা কি ওপেন অ্যাঙ্গেল না অ্যাঙ্গেল ক্লোজার, এটার জন্য আমার অ্যাঙ্গেল দেখতে হবে। তাহলে গনিওস্কোপি করতে হবে। গনিওস্কোপি করে আমি পেলাম যে অ্যাঙ্গেলটা ওপেন, তাহলে আমি এটা বলতে পারলাম ওপেন অ্যাঙ্গেল গ্লুকোমা। এখন এটাকে প্রাইমারি বলবো না সেকেন্ডারি বলবো, তার মানে কি আমি যখন এক্সামিন করতেছি আমি তো একটা এস্টাবলিশমেন্টে যেতে হবে এটা কি ধরনের গ্লুকোমা। তো এটারে ডায়াগনোসিস করলাম আমরা ওপেন অ্যাঙ্গেল গ্লুকোমা। ধরো প্রাইমারি, আমি কোনো সেকেন্ডারি মানে কোনো কজ পেলাম না, এখানে কোনো ব্লাড সেলও পেলাম না, এখানে ইউভিআইটিস পেলাম না, এখানে লেন্স প্রোটিনও কিছু পেলাম না, তাহলে প্রাইমারি ওপেন অ্যাঙ্গেল গ্লুকোমা। অ্যান্ড ইট ইজ দ্য মোস্ট কমন ইন আওয়ার situation, that is Asian people are more commonly affected by primary open angle glaucoma. So we have come to a diagnosis. Then we go through visual field analysis. As we do it in confrontation test, this is not very much helpful. The visual field analysis will help us. It helps us by diagnosing the visual field constriction as well as for prognosis, as it is a long-term disease. eh? So we will compare it with further. And in case of glaucoma, we have to have a follow-up schedule. First, when we first diagnose the glaucoma patient, then we give them a re-examination schedule after 1 month, then 3 months, then 6 months, then every birthday, that is every year. In this way, we examine the glaucoma patient. The examination, we have come to a conclusion that this is primary open angle glaucoma. Then we should set a target pressure, and এই টার্গেট প্রেসার সামনে রেখে আমরা তার মেডিকেশন দেব। I have already mentioned that as the medication should be continued lifelong, so the drug should be less cost effective. And timolol is most effective, and it is only 2 times daily dose and easily available, less side effect, only bronchial asthma and bradycardia accepting. So we will prescribe if the patient is not bradycardic or bronchial asthma, prescribe timolol, and after 1 month we will measure the intraocular pressure and visual field analysis. If we see that the pressure is at 28 or 26, this will be positive. 26, that is the pressure decrease in first follow up 4 মিলিমিটার যদি কমে, এটা আমাদের জন্য ঠিক আছে। যদিও পেশেন্টের জন্য ঠিক নাই, কিন্তু আমার টার্গেট প্রেসারে অ্যাচিভ আমি 1 মাসে করব না, ইট উইল টেক টাইম। Then we will continue the drug. If we see that the pressure is still 29 or 30, then we will think that this drug will not working. Then we may use another drug, or combined drug may be found. It is available in our country, timolol and alpha 2 agonist, that is brimonidine. And then after 3 months, the patient, if the pressure is not controlled, then after 1 month again we give him a follow-up visit. And in that case, if the pressure is reduced, we give him a 3 months follow-up visit. And in that way we control the pressure. If the pressure is not controlled after 1 to 3 years, or if the patient lives in a remote area where he cannot get the drug, or he is not using the drug regularly, this will be harmful to him. In that case, we will make him to understand that the pressure should be reduced to low level. You cannot do it, so you should go undergo surgery. If the patient is ready to be undergone surgery, then we will do it. Thank you all. Today our class is about glaucoma. If we take the class in another day, then we will say about the angle closure glaucoma. Okay.